I'm sure you've found yourself in a scenario where you are about to leave the house, you close the door, you think to yourself, did I really turn off the stove? You go back, open the door, and check, and you find out that the stove is off. You close the door again, and you think to yourself, did I really switch off the stove? Then you repeat the sequence. In some individuals, it may seem like as if it's a usual day, but others will keep having these thoughts ruminating in their mind. Let's talk about obsessive-compulsive disorders. Grab a piece of paper, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at obsessive-compulsive disorders. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so that you never miss on such amazing content every time I post. Grab a piece of paper and your pen and let's go. So, there are two important terms that I want us to know that are in psychiatry not really often used currently. One of them is neurosis, the other is psychosis. Remember, we don't use these terms wide, and the ICD, which is the International Classification of Diseases, the 10th edition, actually discourages from the use of the terms neurosis and psychosis. But generally, these terms are not perfectly described, and generally, there are some exceptions to the rule. When we talk about neurotic, stress-related, and somatoform disorders, the ICD classifies them into three main groups. We have the phobic anxiety disorders, which include things like simple phobias, specific phobias, like for example, you have people that are afraid of heights. You have, for example, agoraphobia, which is the fear of going out into public places. You also have other anxiety disorders, which are simply referred to as anxiety disorders here. Just, for example, we'll talk about generalized anxiety disorder. Then you do have obsessive-compulsive disorder, which will be the main discussion of this video. Remember, neurosis means to do with the nerves, or neurotic disorders is simply a traditional term where the symptoms are going to be arising and they're not due to any organ-brain disease, psychosis, or any personality disorders. Often, neuroses are going to be accompanied by emotional, cognitive, behavioral, as well as somatic symptoms. These neuroses are often but not always associated with an external trigger, so there will be some external stressor that is present. And the hallmark of them is that they're largely associated with anxiety, although in some selective cases we may have depression also being present. The cognitions are eventually going to be worrying, fears, and concerns that are inappropriate or excessive, but by definition not part of a delusion. Remember also that behaviors include avoidance and other strategies that are intended to reduce the anxiety, such as repetitively checking, and somatic or physical symptoms not explained by a medical disease but associated with tension, autonomic arousal, as well as hyperventilation, such as aches and pains, bowel disturbance, and breathlessness are often common with neurosis. Neurotic disorders may be present with emotional anxiety, for example, panic attacks, but may also be present with other symptoms such as cognitions, for example, recurrent worries about having a serious medical condition, or other behaviors such as agoraphobic being unable to leave her house, or somatic symptoms such as palpitations. So what exactly is obsessive-compulsive disorder? So it consists of two components, an obsession and a compulsion. So an obsession can be defined as follows. It could either be an idea, an impulse, or image which generally just intrudes into the conscious awareness of a patient repetitively, and it's going to be recognized as one's own idea and the impulse or image, but is actually perceived as ego-alien, foreign to someone's personality. It is going to be recognized as irrational and absurd, but generally insight in these conditions is often present. The patient is often going to try many times to resist against it, but it's like they are unable to. And failure to resist is often going to lead to marked distress. Obsessions are often followed by compulsions, and compulsions are going to be defined as a form of behavior which usually is going to be following obsessions. It's going to be aimed at either preventing or neutralizing the stress that is arising or the fear arising from the obsession. And this behavior is not realistic and either irrational or excessive. It may actually even interfere with the day-to-day life of an individual. Remember, insight is present, so the patient realizes the irrationality of this compulsion. The behavior is going to be performed with a sense of subjective compulsion, which is pretty much an urge or an impulse to act. Generally, obsessive-compulsive disorders, or OCD, have a lifetime prevalence of about 2 to 3%, and the mean age of onset is roughly around 20 years. There is no gender predilection for OCD. According to the ICD, which is the International Classification Diseases, the 10th edition, there is now an 11th edition which is released, and you can actually check that out. It's classified into 3 clinical subtypes. You have those that predominantly have obsessive thoughts or ruminations. You have those that have predominantly compulsive acts or compulsive rituals, and you have the mixed obsessional thoughts and acts. So you could either have predominantly obsessions, predominantly compulsions, or a mixture of both. Remember that depression is very commonly associated with OCD. There are 4 clinical subtypes that have been described according to literature, and usually an individual will have a mixture of these subtypes as opposed to having individual pure syndromes. You can have washers, which is the most common type, where these people are obsessed with the contamination with dirt, germs, body excretions, and the like. So the compulsion here is that they're going to be washing their hands and their whole body repetitively number of times in a day. Second clinical syndrome are the checkers, where the person is just going to be constantly obsessed with usually the safety of something, and this leads to them repetitively checking. The scenario I gave you about the stove. You do also have pure obsessions, where there is a syndrome which is characterized by these repetitive intrusive thoughts. You may have impulses or images which are not associated with compulsions. The content is usually sexual or aggressive in nature, and the distress is often associated with the obsession. With these obsessions is dealt with usually by counter thoughts, such as counting, and not by behavioral rituals. So often these are not going to have these compulsions. A variant of obsessive ruminations, which is a preoccupation with thoughts, can be seen. And here the person actually repetitively ruminates in his mind about the pros and cons of the thoughts that are concerned. The last clinical syndrome is known as primary obsessive slowness, where it's actually relatively rare, but it's going to be characterized by this severe obsessive ideas or extensive compulsive rituals in the relative absence of manifested anxiety. This may actually lead to marked slowness in daily activity. Management includes certain modalities such as psychotherapy, behavioral therapy, cognitive behavioral therapy, pharmacological drugs, electroconvulsive therapy, and in some cases, psychosurgery. In psychotherapy, you get the psychoanalytic psychotherapy, which is used in a certain selected number of patients who are psychologically oriented. Supportive psychotherapy is actually important, as it can be used as an adjunct to other treatment modalities and often is needed by the family members. In behavioral or cognitive behavioral therapy, there is behavioral modification, which is an effective mode of treatment with a success rate of about 80%, especially for those that have compulsive type of disorders. Techniques include thought stopping and its modification, response prevention, exposure and response therapy, systemic desensitization, as well as modeling. Pharmacological drugs may include antidepressants. Some patients may actually improve drastically with specific serotonin reuptake inhibitors. Antipsychotics, though these are usually given at a low dose, including drugs like haloperidol, risperidone, olanzapine, as well as other drugs. This can be used in the treatment of severe disabling anxiety. Benzodiazepines, such as clonazepam, have a limited role in controlling anxiety as adjuncts and should be used very sparingly. Buspirone has also been used to be beneficial as an adjunct treatment to augmentation of selective serotonin reuptake inhibitors in some patients. And in a bracket of patients, they may actually go for electroconvulsive therapy. That's in the presence of severe depression with OCD. This is an indication for electroconvulsive therapy, and it's particularly indicated when there is a risk of suicide and when there is poor response to other modes of treatment. However, electroconvulsive therapy is not considered as the treatment of choice in OCD. In a selected number of cases, there may be psychosurgery that can be used in the treatment of OCD, and this is for those patients that have become intractable and not responding to other modes of treatment. It is worth trying. I really hope you learned a lot when it comes to OCD. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.